Hello, good morning, everyone. How are you all doing?
Very good.
Wonderful. We will get started here, I think, because we don't want to take up too much time from our wonderful speaker. Thank you so much, Jennifer, for being here. Kara, would you mind to introduce these slides and then I will do the introduction to Dr. Ridgeway?
Yes. So good morning, everyone, or afternoon if you're on the East Coast. We are excited to be back from our summer break, and we are really excited to have Dr. Jennifer Ridgeway be our presenter today, who will talk about moving at the speed of pragmatic science to identify and track adaptations. And so we just have a few announcements, and then I will pass it over to Borshika. And I will put all of the links that you see in these slides in the chat, so don't worry about trying to write down these URLs. And then just so you know, if you end up having to leave early, we will be adding the meeting recording to our website, and I will put the link in the chat as well. So one announcement is the D&I Models in Health web tool. We are looking for instruments, looking for qualitative, quantitative, and mixed methods. We would love for you to submit any instruments that you yourself have developed, or if you know of an instrument that is not currently on our list, you don't have to have developed it. Feel free to submit it through our form. The D&I Models in Health web tool is a web tool that helps both researchers and practitioners of implementation science be able to apply theories, models, and frameworks. And we have added our new assess section, which includes different implementation measures and tools. Another really great feature, if you are not able to submit an instrument, is to provide a review or rate existing instruments, or you can actually do this with the theories, models, and frameworks that we have listed on the web tool as well. It's a really easy way to be able to share your feedback on the instruments and the frameworks. And comments will be reviewed and approved by our team, as well as the instruments that are submitted. Feel free to check out the web tool when you have a chance. It's a fantastic resource for anyone looking to conduct implementation and dissemination practices. So September is our DISC and InStep Center seminar. It will be on Thursday, September 18th. This will be our part 2 of the InStep pilot awardee presentations, and we'll have Dr. Sarah Chung and Yesenia Mejia present on their pilot study exploring psychological safety in racially, ethnically diverse school mental health teams. Another really interesting thing that's happening both this month and next month. The Center for Implementation and the Society for Implementation Research Collaboration is going to be holding a virtual panel looking at careers beyond academia on September 16th. And then a month later, the DISC and InStep Center will also be hosting a virtual panel around careers outside of academia. Both the panels are very different, where the Center for Implementations is a little bit more focused on looking at non-traditional careers, and then our panel is more around industry. We have folks from nonprofit and two digital health private groups as well. And then our upcoming AFT meetings. So we had a little bit of a change. So our October meeting is going to be held on October 6th. The speaker we're working on finalizing right now. The original speaker was going to be Dr. Kelly Ashbrenner, but she is going to be presenting in December. And then November, we will have Dr. Erin Kenzie present on causal loop diagram and adaptations. And then January will be when we hold our group discussion around the D&I conference. I also want to say that registration for that conference is open. And so feel free to register, and we will also be there as well, representing both UCSD and Colorado University, and highlighting the D&I models in health web tool. We are looking for nominations, speaker nominations for our 2026 series. So if you or you know of someone who might be interested in presenting at one of our AFT meetings, feel free to submit a nomination through our request form. So now I will hand it over to Borshika to introduce our speaker.
Thank you so much, Kara, and thank you everyone for being here and rejoining us, as Kara mentioned, especially to our speaker, Dr. Jennifer Ridgeway, who agreed to talk about their work around adaptations. Dr. Ridgeway is an associate professor of health services research and senior associate consultant in the Robert D. and Patricia E. Kern Center for the Science of Healthcare Delivery at Mayo Clinic, where she previously served as the scientific director of the Implementation and Evaluation Science program. Her research focuses on the use of networks, technology, and collaboration to increase access to patient-centered, compassionate, and evidence-based care close to home, especially for people with cancer and chronic conditions. As an investigator in Practice Embedded Research Center, she is also interested in the intersection of quality improvement and implementation science to achieve rapid improvement while solving persistent healthcare problems. And the title that Kara already shared, I think, aligns with this expertise and interest. So thank you so much for coming to talk to us. And I will hand it over to you now with the caveat that I would like to encourage everyone to use the chat during the presentation. And perhaps we can help you if there is something that comes in that could be addressed immediately, or just hold the questions to the end.
Yep, feel free. Let me start this slide share mode here. Feel free to interrupt me if there are timely questions. I do believe we should have plenty of time at the end, so either way is fine. With this view, I can't see much of the chat or raised hands, so apologies if people have things that I don't attend to right away. Does this view look okay to you, Karen Porshka? All right. So thank you so much for having me. I was delighted that people read this paper and reached out and were interested in talking about it. It was an interesting experience of thinking about kind of pragmatic, rapid ways of tracking things that were going on in this large multi-year study. And it gets a bit to my interests in figuring out how we do things well, but we also think about how to integrate them into systems where we have people already overburdened and people with varying expertise in different scientific fields. I titled it Moving at the Speed of Pragmatic Science. I think you'll see as I talk about our process about how we were tracking many, many things going on all at once. I won't spend time talking about me because it was such a kind and comprehensive introduction, but I'm sure many of you are also working in this space of technology-enabled, community-based, community-placed interventions. I do work a lot in cancer and chronic conditions in things like hospital at home, community paramedicine, other trials like the one that I'll be talking about today that use technology to extend care. So this is Mayo Clinic. I am in sunny Rochester, Minnesota right now. We have an enterprise location here in Arizona and in Florida. The top picture is Minnesota. It doesn't look anything like that right now. It's a massive construction zone where that grass used to be as we go through a $5 billion expansion to think about how we reorganize our facilities and our care teams to deliver more patient-centered care. So it's a massive construction zone, but with the hope of doing some great things around new models of care in the future. The study I'm going to talk about took place in the Mayo Clinic health system as well as in Rochester. So it's that top map that extends into all sorts of community practices in Minnesota and Wisconsin. I'm also doing some work in organizations around the country that are part of the Mayo Clinic Care Network. So I'd be happy to talk more about those if people have interest. So this is a paper. I put the QR code here in case you need to go back to that. I framed the presentation today to walk a little bit through the results, but more so to talk about what we did and kind of the general benefits and drawbacks of what we did as practitioners. And so I'm hoping to get your feedback on that, and I'm happy to talk more about the actual results too, but I'll try to do things, present things that might be of interest to you methodologically. So again, this was done as part of what we call the E2C2 trial. It is part of the Impact Consortium, so it was one of a number of studies that was funded a few years ago through Cancer Moonshot. All studies looking at EHR delivered interventions around cancer symptom management that involved patient-reported outcome measures, or EPROs. Our study, and I'm just going to do a couple slides just to give you background on what we were adapting and tracking. Our E2C2 study was built on the collaborative care model. So we used EPROs to assess patients at any point in the cancer continuum with any type of cancer being seen in an oncology practice. So some newly diagnosed, treatment, survivorship. We use PROs to understand kind of quality of life symptoms, these SPADE symptoms, things like sleep disturbance, pain, anxiety, delivered through the portal. And based on how people answered, we triaged them to self-management materials, to a remote interventionist called a symptom care manager. But really it relied on the collaborative care model principles, which are that we deliver the amount of care that is needed based on the patient situation, and that there are also kind of two clients. There's a patient-facing part of this intervention. We deliver self-management types of intervention, and also a care team part of that intervention. So through the EHR, we're making some information about cancer symptom management, how their patients are doing, delivered through the EHR to clinicians. Again, the detail of the step wedge design is not important, but as I walk through how we tracked things, just know that it had the traditional cluster randomized step wedge approach. So we had things that happened when we got the grant. We had things that I would call pre-implementation. And then we had clusters of clinics randomized to start across these 5 sequences. So in each time period, which I sometimes refer to as, the first, the second, the third, the fourth, the fifth, we're doing refinement, adaptation, and tracking what's happening across multiple clusters of clinics around the health system. So in Rochester, it might be the endocrine group and the breast group and the colon group, and then it's 3 community-based generalist oncology practices getting these interventions. The intervention I already kind of described. It's based on EPROs. People with moderate symptoms get self-management. People with severe symptoms get a symptom care manager who's like a remote interventionist. And we also deliver things to the oncology care team through the EHR to help them manage their patients. Our implementation strategies, and I would consider this like the baseline bundle. When we got the award, this is what we said we were going to do. This was our intervention, and we had 3 strategies. Practice alerts, so like BPAs, OPAs, audit and feedback, so providing information back to the care team on their performance, and then practice facilitation. So each of these clusters, these clinic groups, assigned what we called a symptom sage, and they were our internal facilitators, and they were in charge of all of the things that implementation facilitators are often in charge of, and relaying information and championing the change. And then they met collectively with a study team member as well. This looks like a flow diagram, which looks maybe not super interesting, but I'm going to spend a minute on it, because when I say that first big chunk of all the tracking we did was based on essentially a project management study design. And so we had a steering committee that was responsible for all of the things that were happening in the study over time, from the time we got it, all of our assessments during pre-implementation, all of our engagement with care teams, and all of the work that continued around data collection and engagement throughout randomization. All of that was overseen by a steering committee, but also a work group structure. So it's a very large trial with a lot of different things that needed to be refined and built at program funding, for example, all of the EHR systems so that you could deploy the EPROs, all of the algorithms that sent information to nurses or care teams. All of that was still kind of being refined in that pre-implementation period, finalizing patient education materials. All of that was happening. It was happening across all of these different work groups. So I was a member of the implementation and evaluation work group. And you can probably, coming from your disciplines, understand where some of these intersections and overlaps were happening. We had a clinical engagement sub work group, for example. And over time, we started to realize all of the implementation people are also on the clinical engagement team. And so some of these work groups morphed a little bit over time. But there was such a vast amount of information that our project manager started right from the get-go to document everything that was happening in every work group at the end of the week. He was collating it, putting it in a spreadsheet that was reviewed by our implementation team, and then sending it out as a summary at the end of the week to say, just so everybody knows, these are all the things that happened across all of the work groups. We took that information back to our implementation and evaluation group and I'll show on the next slide what that looks like. Took a look at it because we started realizing right away that this is the kind of information that was going to be rich for future analysis. So this is just an example of a few entries in the spreadsheet toward the beginning of the trial, and the type of information that the project manager would populate, and we would organize essentially into buckets. So there were things happening around engaging the practice, doing presentations, training staff. You'll see some things around strategies to address what might be determinants, like, resistance in the practice to get patients to fill out more surveys. Some real logistical things that we managed, like some systems didn't have tablets. And a lot of problem solving happening early. So as an implementation science team, we started to say there's actually a lot of really rich information in here that will be helpful in the future that we should be documenting now. So we continued with this practice throughout the entire duration of this study, every week looking at what had happened across all of the work groups, organizing it by date, and then in some rough category. So now we had one tool, which was just keeping track of everything and knowing that some of it looked like we were making important decisions or we were capturing important determinants. But we also started to realize that a lot of decisions were being made, and they were often being made really quickly. And we didn't necessarily have a great way of tracking how we were making decisions about adaptations and tracking reasons for them. So we started using the framework to look at intervention adaptations and to think critically about which ones we should be doing based on whether they were a core component of the intervention or not, and keeping track of the reasons. At the same time, the implementation science work groups across the consortium were working under the direction of J.D. Smith on developing lists, which is the longitudinal implementation strategy tracking system. So now we had a third tool of all of our activity, everything that is happening. We have systems for tracking adaptations and thinking critically about when we should make adaptations to the intervention. And we have a third one, which is tracking implementation strategies. I used the visual of the kind of measure twice, cut once, because it was a real impetus to think not just about the speed of capturing everything we were doing, but how to bring to our steering committee a proposal to say, you know, you're making decisions often. How do we put systems into place where we're deciding which of those adaptations we should do, and engaging you in thinking about why you're, some of those prompts from Frame, why you're doing those types of adaptations, what are they responsive to? Because that will be rich data, both for our analysis and for future scale up. So we had 3 different systems, and now we're starting to think a little bit more critically about what each of them does. You know, again, measuring the breadth of everything, making deliberate changes to the adaptation, and tracking in time the implementation strategies that we're using based on this new list approach that many of you may be familiar with. So these are the results, and I won't spend a ton of time on this. They're all in the paper. We documented 187 things that happened during the course of the study, and that weeds out on data cleaning a lot of technical things that were captured, things like communications with NIH and some decisions. All of that filtered out, 187 discrete things. And we took a look at how much of that, the primary impetus being how much of the intervention things happened after we got out of pre-implementation. But just looking kind of at broad strokes at this table, you know, about 1/3 of everything happened in pre-implementation, which is kind of where we expect. You know, now you got your award and you have an intervention, but now you got to make sure everything is in place to make it work, and you're talking to care teams to make sure it's going to fit their workflow and all of those things. So not at all surprising that a lot of that work, the intervention, the EHR build, and the practice engagement in particular, are happening early on. But you can also see that there are things related to the intervention that continue to happen throughout. And some of those are little changes, and some of those are more substantive changes. Early on, we added a health coach. So we have a remote interventionist, and we started having more conversations about action plans and what about patients who needed more help developing action plans. And so we added a health coach. Later on, we added direct referrals to PT and social work. So a lot of the patients who reported symptoms in related categories would talk to the remote interventionist, and then she would just end up making a referral to the PT, the physical therapist, or the social worker. So we changed that workflow, and we added 2 new people to our intervention team. There was also a lot going on that got classified as operations, and it was related to the COVID-19 pandemic. So the way that we delivered care, the way that we delivered remote care even, was, like many of you, I'm sure, was pretty significantly impacted by the pandemic. So we coded those as operational COVID things in the beginning. But those are the types of things that when we reflected on this later, we started to see where things may have been coded as kind of operational, but they really were an implementation adaptation or an intervention adaptation. And I think this is one of the kind of key considerations of a system like this, is that you're tracking everything. But it takes some level of implementation science expertise sometimes to go back and think, were we actually making a change to the intervention, or was that just an activity that got tracked? Tracking everything and going back and then thinking about what that was happening, I think was one of the strengths of the system. So I'll talk a little bit about that. We only tracked 11 things in Frame that we considered intervention adaptations. And so And there's a lot of data behind this now, like the reasons for the adaptation and who recommended the adaptation. Almost all of our adaptations were recommended by our symptom care managers, those remote interventionists. But this is really also where we borrow this red, yellow, green system of decision making. So now every time someone proposes something that appears to be an intervention adaptation, we're bringing it to the steering committee. We're saying, this is the proposed adaptation. How core is this component? Is this something that we can change, should change, can't change? And then kind of forcing our steering committee to walk through some of those constructs and frame some of those prompts so that we can capture some of these reasons for analysis later. I will note that only the approved adaptations end up being tracked in the database. So one of the limitations I've noted is that we probably considered other things that were not approved that didn't end up being tracked. Likewise, there were probably a lot of things that were just in that green category that were easy adaptations that we didn't slow our steering committee and our systems down to interrogate and enter information about. So we really only have 11 that were entered. And then we have lists. And again, I'm not sure how many people are familiar with lists, but lists is a system of tracking implementation strategies over time. Again, spearheaded by J.D. Smith and using this impact consortium as an opportunity to have all of our systems use lists and track it and then evaluate its utility. We had 33 strategies. Almost all of them were related to, I would put in the category of training and educating stakeholders to improve our intervention reach. Most of the strategies were planned in advance. There weren't a lot that I would say were completely novel implementation strategies that we didn't plan in advance. There were some core changes to how the intervention was delivered. This first one being a change from an opt-in to an opt-out and a return to an opt-in. And it gets at this question of, do you deploy EPROs and just give everybody the intervention if they score poorly? Or do you say you scored poorly? Would you like to opt into the intervention? And we changed that a few times over time to respond to our desire to reach more people and then to respond to the need for efficiency where our interventionists didn't have time to talk to every single person, many of whom didn't want intervention. And then the second was the addition of interactive voice response. I don't know if anyone is using that in their research, but for patients who didn't answer EPROs through the portal or when in clinic, we use interactive voice response, which is a telephone system. So you get a call, a bit like a robocall. It's an automated call where you could answer your symptom questionnaires by pressing the keys on the telephone pad. We also had some minor adjustments to things like our practice facilitators, how often they met, how we selected those folks. All of this information, again, lists and frame.is all capture a large amount of information that you can use later in your analysis. So I have not presented this all here. The kind of the way to tie this all back together was the use of a logic model. So again, you have kind of three disparate tools doing three different things. And so at the end of this study, we were kind of like, well, how do we use all the information from each of them to understand what our core components were? That was one of our objectives. And try to understand kind of some rich information about that would inform scale up. And so we used a logic model approach, and my background is in evaluation, so I really like logic models. You may have a love or hate relationship with logic models, but I like the logic of logic models where you can use them as discussion points with people. And so we as an implementation team were able to populate the logic model and then engage our work groups and our steering committee to make sure that it made sense, that we were agreeing what the core components were, that we were thinking critically about whether we had any changes to the proposed mechanisms of change. And then that kind of became our final bundle of what our intervention looked like and what our strategies look like compared to that kind of original bundle that I proposed in the beginning. So this is the final logic model, and I won't expect you to read all of it. So I highlighted just a few things. If you've used the implementation research logic model or the IRLM, this will look very familiar to you, where we used CIFR as our determinants model for this study. So you'll see kind of CIFR related things in the determinants column. We've included our implementation strategies and our intervention along with the mechanisms of change and our outcomes. And in this, what we're calling kind of our final logic model, I've underlined which things changed, what the new things were, and then the dates of those change. So as we've started to evaluate, our study is now done, we're starting to publish on our outcomes, we have kind of a source of truth for what our implementation bundle and in our intervention was, and at what point in time we saw some of these changes occurring. So in this, the clinical intervention, as I noted, we have some new interventionists, just as one example. We started with just RNs managing patient systems, and then we expanded that team to involve a number of different individuals. The implementation strategies, we had a couple of changes in implementation strategies that I noted. At the core, the implementation strategies are not vastly different, but some of them did change a little bit. They would still fall under, train and educate stakeholders, for example, but we did make some modifications to how that's done, which had some implications for our mechanisms for those strategies. So I want to talk just a minute about the strengths and limitations, and then I want to open it up. I don't see the chat comments, but I see that there are some numbers on the bubble. So when we sent this paper out for review, a lot of the questions were around the limitations. And so I'll note what I think are some strengths, but fully acknowledge the limitations of this approach. I think a strength is that this Excel table that I showed had kind of brief descriptions, and they served as prompts. And so in some of the early meetings, when we were reviewing the spreadsheet, I was pushing back a little bit and saying, oh, we should say more because this is really interesting. Like this fact that we had to go in and retrain the desk staff, like, why was that? What's the determinant? What kind of rich information can I get out of this? And I think what we found is that we had to find some balance, that the whole benefit of this activity tracking system was that it was easy for people, that the work groups were already doing a lot of stuff and they were documenting in brief notes what they did that week, and we could capture that. And we could reflect on it and organize it and add a few little notes so that we would have detail. But it also became a good prompt for recall, where at the end of the study, we could go back, and even though the note sometimes was rather brief, had enough information there that we could understand the change that had been made. The second strength is that we did identify other categories relevant to adaptation. So if you just put the project manager in charge of tracking, things that are tracked as COVID, for example, and operational in nature, we may not have noted actually resulted in some types of implementation adaptations. So having that second review made it easy for the project management team and other work groups to kind of simply document what they were doing. And for us who had, some dedicated time and some expertise to reflect on that and to see where things might be related to adaptations. I think in that way, it kind of balances what everybody has to do and what their expertise is. The project manager was the critical kind of linchpin in all of this, and that was their area of expertise, was thinking about how to gather information from all of the groups and store that. And our expertise was to review that and classify that using the lens of what would be an adaptation. And then thinking about kind of the strengths of these multiple tools and bringing them together. Again, I really like logic models. I like that they help us think critically about what core components of interventions are, but they're also really discussion oriented. So being able to put something like that in front of a steering committee I think it serves as a nice tool for all of us to kind of come to consensus on what that final bundle look like. And then the other tools like FrameIS, lists, capture all of that kind of rich information, detailed information about our adaptations, our reasons for them, etc. The limitations, we did develop things midstream. So we started with this tracking everything approach. We determined we needed to be more thoughtful or a little bit slower in some cases about making adaptation decisions. And so we built a workflow around kind of the red, yellow, green. Which of these adaptations do we want to make, and then populating Frame to capture that information. List was created as part of this large consortium, so it was not available until later in the study. And so we were kind of retrospectively filling in some of that information. In terms of kind of that activity log, even though we were trying to find that balance of, burden and detail, I think the work groups, we still let them decide what to include. And so sometimes people don't note that the things that they're doing are actually really important implementation types of decisions. They might just think of them as a very standard thing that they did in their work group and not even capture it. So I think a downfall or a limitation at least is that still what we were able to capture and track relied on what they felt was important enough to document in the first place. We did have a dedicated project manager. When we published the paper, we did some work to try to determine how much effort that took. I think that was a big pushback from reviewers, was it still seems like an awful lot of work. And it was about an hour of time for him to kind of collate things and for us to review it. We did that weekly as a team in about the last 10 to 15 minutes of our work group meetings. It does require a really dedicated and committed steering committee. So asking people to go through the Frame and the FrameIS prompts and think about why these adaptations are being made it takes a lot of time, and as when you have a million things going on in a large study, I think they were generous in their time and stopping what they were doing to fill out these types of things with us. And then I already noted that we only captured in some of these systems adaptations that were made. So what we miss is all of the things that were maybe considered and set aside. It really only gives us a picture into what was done. So future considerations, I think one, and again, the pushback we got when we shared this work is that it seems like a lot of burden. And it is. I think the balance we were trying to find is how much burden is necessary, how much is already happening anyway. And so I think the second bullet here is the one that resonates with me the most. A lot of stuff is happening, and they're moving at the speed of science, pragmatic science. Like we're building sometimes the plane as we're flying it, and lots of things are happening across a lot of different work streams. How can we capitalize on the documentation that people are already doing, and organize it in such a way that it's useful? And again, thinking about the fact that people come from different disciplines. So our quality colleagues, our project management colleagues, our, Epic colleagues are all documenting stuff. We're just trying to find a less burdensome way to capitalize on what they're already documenting and using it. But again, that's a future consideration for how much to track. And then who champions the work? Do you have a project lead who's saying, yes, we are going to devote time in our steering committees to thinking about our adaptations and to tracking things? Or is it something that doesn't rise to kind of that level of importance? There are some trade-offs for kind of real-time and retrospective tracking. I talked a little bit about that. There's the burden of keeping track of everything, but some of that is happening anyway. And then there's the burden of going back and trying to piece together the picture of what happened. And then there is some sense of redundancy. I think we did have 3 different systems, all tied together in a logic model, and there are some redundancies there. But I do think that, in that redundancy, sometimes we found things that would have been missed in one system and were captured in another. So I think what the takeaway for me and our teams is, can we take what we learned from this project and maybe simplify that tracking a little bit, and be more thoughtful from the beginning about who's in charge of tracking and budget time and effort for that, to make this a more feasible approach in the future. And with that, I want to leave time for questions and conversation. I am using kind of a similar approach right now in a small project that doesn't have, that has a project manager, but not a lot of other work groups assigned, just to think how this might translate to a smaller project that, isn't a big U grant with multiple work streams. Those are very different from the small internal, remote patient monitoring project. But trying to draw on the principles of, what can we keep track of that's already being done and that tells us something about adaptation and informs future scale up. So I appreciate that I went through that quickly. I tried to lean in on more of the methods and the approach, hoping that we could have a conversation about that. But whatever questions you have, I'd be happy to hear them. And also your suggestions. You're all experts in this field too. So whatever recommendations you have or suggestions, I'm happy to take those as well.
Thank you so much, Jennifer. You did such a beautiful job really focusing on the methods that we geek out on in this group, but also talking a little bit about the results. I see questions in the chat, so I'm going to invite people to come on if they can to state that question. Russ and I also already dropped some questions in there, so we can resort to those if others don't have questions. But let me start with one that was mentioned by, and this is, I'm not even going to attempt to pronounce the name correctly. Well, I'm going to attempt at least. Is it Jyotsna?
Yes, it's Jyotsna. That's right.
Oh, wonderful. Would you mind to state your question, and then that will help Jennifer?
Yes, sure. So I was interested in the data management aspects of the tracking, and you mentioned Excel and RedCap, but I wanted to know whether you maintain like different projects, and like how did you carry out this whole process of tracking in RedCap particularly, because I'm also working on an RCT with an aim on implementation. So I'm right now in the process of thinking how to go about it, and any lessons you have learned from the methodology that you use for data management that I should be considering. Yeah, that's my question. Thank you so much. Excellent
Yeah,
presentation.
Thank you. I would be happy. And I'll just kind of talk through the pieces, and I think I'll hit your questions, but let me know if I don't. So the first tool, the activity tracking, we did use Excel. And in that case, I think Excel worked well because it was something that the project manager could populate and was easy on the screen in a meeting to pull up and say, yep, these are all the activities we had this week. What's the core of this? Is this an implementation thing? Did this, reference an operational thing? Or where does this belong? Excel is a really easy project management tool, but it's also accessible to almost everyone, right? Oops, I hand waved and it raised my own hand. So I think that worked really well. I don't know that I have a better recommendation for that one, but I do think if you have buy-in that everybody is kind of collaborating across teams and that the project manager is owning it, and then the work group people are also jumping in to edit, that's just an easy tool. The other ones, and anyone could populate those, they're on SharePoint and anybody could own those or populate those. The other ones were in REDCap and needed to be populated by a member of the study team or a member of the implementation group. Entering things in REDCap or Qualtrics or some other database type solution is great for organizing that type of data for analysis, which has a lot of structured data fields and response options. They were separate in that the intervention adaptation one, the one that built on Frame, was just something that our project did. And I think I saw a question about what did the consortium do versus what did we do? We were the only study that used Frame and tracked implementation or intervention adaptations. We brought that kind of rubric to the steering committee, that red, yellow, green. And I really do think it was mostly, well, we know in our tracking system that it was mostly yellow things that were in there. The red wasn't going to make it in there. The yellow were things we were really talking about. They were like, were they core? What would happen if we changed them? That's kind of that yellow criteria. The green stuff is more like just go ahead and do it stuff. And I think a lot of the green stuff didn't make it into that database. But we tended to take those frame questions to our steering committee and use it as almost like interview prompts, so that we could think through the adaptation. And then we took on the work of entering that in the database as the work group. The lists one, has a lot of the FrameIS kind of constructs, was built in REDCap, again, in part because it was done as a member of the consortium. And so we had similar projects across all of the different funded projects. We all used lists. And so that created a nice database that you could export for our own analysis, but it also made it very consistent with the other funded projects so that we could think about analyzing. Again, these big consortium projects are meant to advance the field by having some kind of shared things across. So we all had projects for different interventions, but all kind of related to implementing EPROs and symptom management in some way, leveraging the EHR. So it creates a system to share. I don't know that I have a better, anything you can enter survey data in, essentially, which is a lot of what these tracking systems are, is asking questions. Many of them structured, I think would be fine for data management. But I do think the first one, which is very project management and creating in simple language that anybody on any workflow or any work group could contribute to, that something simple like an Excel, and then I exported that data for analysis. It's very descriptive types of data on counts. So
Thank you so much.
yeah.
Thank you so much, Jennifer. So many good questions are coming in. I'm going to keep picking. Just mentioning from Gretchen that And I would just state it, Gretchen, I apologize so I can get to questions, but thank you for sharing your IRLM. What a great visualization of both implementation and intervention mapping. When doing more of a hybrid approach, I have been wondering how to integrate the two. So she really found that helpful. And then we have a question. Russ was wondering how many impact projects were there?
There were 3. I would have to, one of them was a consortium of different organizations. So it actually was more settings than 3, but yes, thank you for
And
asking
if I
me
could,
and
yeah,
making me jog my memory.
well, I
now.
should know that too, or remember, but just a quick follow-up
Yeah.
on that. When you talked about the steering committee, that
Yeah.
was the impact-wide steering committee, or was
No,
that
sorry, the E2,
your
yeah.
project per se?
Yeah, so E2C2 had a steering committee that
Okay.
managed this work. And across the consortium, so folks from Northwestern and Dana-Farber and others across Dana-Farber's consortium of settings had an overarching steering committee. Again, with this desire to make things kind of to populate better generalizable, transferable lessons learned. And then we had an implementation work group that JD Smith chaired. And so across our centers, we were trying to find some commonalities in instruments that we used, Nomad, for example, and ways of tracking the implementation strategies and developing lists.
Thanks. Just one other quick one, and just chime in to various comments in Borsica's too. Really nice presentation. It kind of gave us just what I think this group wanted and needed. So huge, comprehensive job. Congratulations. But thanks for this focused, relatively succinct presentation. But my last question just on this is, you did say approved. There were adaptations approved. I just want approved by whom? And
I would say the steering committee, though I think if you look at Frame, there is a little bit of like who made the decision.
Yes, right.
And often it's the principal investigator. Sometimes it's the NCI, or so I think there's nuances to what we mean by approved. But Frame gives you a nice way of tracking that information too. But yeah, technically the steering committee.
Okay. Thanks.
Yeah.
Let me go to the next question. This is from Mayuko. I don't know if you wanted to quickly state your question.
Hi, thank you so much. This is a very great presentation. So I'm doing my K project right now. And my question to you is that you mentioned a little bit about the manpower to track all these change. And do you have any advice for early career who has a limited resource, who preparing for large scale, trial later? But I feel like we are still observing a lot of interesting, important phenomenon. And I just wonder, like, do you have any advice to early career how to track those change or adaptation, like, or decision making we are observing at the key level project?
Yeah, I think it's an it depends a lot kind of question. This approach worked really well, or at least as well as I could have hoped in some respects, for a big project with lots of moving parts. But I was mentioning that I'm using this now for an internal project where we're evaluating a remote patient monitoring program for pediatric patients with cancer and febrile neutropenia. And so it's a little project with a small team. But I think one of the things that I'm carrying forward from this large project with lots of activity tracking is that this small investigative team is generating a lot of stuff. They're doing lots of things, they're making lots of decisions, and I'm finding it slow or hard to slow them down and say, let's think about this, let's use a robust approach like Frame or Frame IS. And so I'm trying to find the balance when I can't keep 100% of their attention all the time, to say, at least keep track of what you're doing. Because then we have some source of truth we can go back to. Going back and looking at that activity tracker at the end of the study, so many things I would have forgotten that we had done because we did so much in the moment. And so I'm trying with this clinical investigator I'm working with to find some balance. We want to specify implementation strategies, for example, and track our adaptations and do it in such a way that we advance the field. But also on these smaller projects, I think we just have to do what we can do. So if you're building a budget, I think just acknowledging even the way that you're going to track. I think in a lot of the proposals that I've written, we've privileged for good reason, well-known adaptation approaches and strategy tracking approaches. But we also know that there are huge downfalls in getting people to fill them out. I've got an R01 right now with facilitators in different health systems around the country. And I put them in charge. And then one of the impact groups tried this as well, putting them in charge of filling out the red cap survey, indicating what they'd been doing and documenting their strategies. And I found that to not be very successful. So we moved more to this like a periodic reflection approach, where I can interview and prompt people about the things that they're doing and capture the data. So then the burden of tracking and aligning with concepts from implementation science and populating core measures falls on me. But the keeping them engaged and getting, information about what they've been doing and just generating, more tracking, them just reporting what they've been doing and me prompting to understand why, I think has been, that's a useful middle ground. So your budget on, whether it's a big project or an R1 or a K or an internally funded project, finding the sweet spot of what lessens the burden, but really leverages what those people know, and their expertise is what they're doing, just telling you what they're doing and why they're doing it. And then or in this case, our team's job was to try to understand that with an implementation science lens. So that was maybe a roundabout way of answering your question, but I think we write these sections often just talking about, we will track things, we will use, our implementation science team will do this. And somehow if we can leverage kind of the expertise in the disciplinary kind of lens that all these other people have, it might make for a nice methods section and be more realistic of how it can happen in real life.
Thank you so much.
Yeah.
Well, we are coming to the end of the time. We have 2 minutes. I don't know what else to pick. Well, I might ask one of the questions that Russ was asking about related to pre-implementation, and I already lost it. Russ, did you want to ask it? Do you still remember? It was early on.
Well, I really think it should be your turn, Boris, because you've been answering everybody else. So I'll defer to you. If you don't have one, I might ask one just about the mechanisms in the IRLM and how you used that. And if you're thinking of relating those, there were a lot of them. How you were thinking about relating those to outcomes, if you are. But Boris, I really, I defer to you.
Well, why don't we do that actually? That's a good one, mixing together with one of the questions I had. Did you think about the impact of adaptations, whether it's mechanistically or in other ways? And did you measure those impacts? I think that's the black box right now in this sub area.
Yeah, and since we're about at time, I'll just say two things really briefly about that. The first, I think, is that the logic model and kind of thinking through the mechanisms is a great way to understand if you've changed core components, and if so, how you intend or how that might impact. It's more of a thought exercise in many ways. How do the activities and the outputs relate to the outcomes, and whether any of these adaptations made a difference. I do think that our next phase will be thinking about then, now knowing what our final bundle was and what mechanisms would have been engaged, now we can use those in analysis, right? So I think it's a bit of a two-part for me. The logic model really helps make sure everybody's on the same page about what you're doing and what the impact of those choices are. And then it articulates what your final bundle is so that when you're doing analyses, that's your touchstone for how you set up your approach.
Thank you so much. That could be a full hour of additional conversation, right? To kind of
Right.
come around the challenges with that. But this was so fantastic, Jennifer. Thank you for restarting our full session with such a great presentation. Thank you for the engagement from the audience. It was really great to hear from your questions. And hopefully we can see you all in October, which the TBD or TBA topic that Kara and I and Russ will figure out in the next week or so. So thank you. See you in October. And Jennifer, again, really appreciate your time.
Thanks for having me.
Thank you, everyone. Bye.